Thank you to everyone who is joining us today for the free webinar, Improving Patient Care and Decreasing Costs. My name is Morgan Goldsmith. I am a registered nurse and the Director of Clinical Marketing and Education for Hospice Corporation. And today I'm joined by Dr. Natalie Latuga with Hospice of Buffalo, who will be sharing their recent experience publishing a very exciting paper that we'll discuss in today's presentation, as well as their experience with the Macy Catheter. Here's a quick agenda of what we'll be discussing in today's overview. And again, thank you to all those that submitted questions. It was really interesting to hear all the different questions, especially with some of the information that we'll share in the publication that Natalie and her team were put together early this year, and it was published at the end of December 2018. But for today's presentation, we'll talk through just a quick introduction, a little bit about Hospice Buffalo and the background there, an overview of the publication, which the title is A Cost and Quality Analysis of Utilizing a Rectal Catheter for Medication Administration and End-of-Life Symptom Management. And then we'll go through a brief question and answer. So first and foremost, I'm really excited to introduce our presenter today, Dr. Natalie Latuga. As you can see here, most importantly, she is an incredible mom to these two very cute little girls, Samantha and Allison, and resides in Buffalo, New York. She's worked at Hospice Buffalo since 2011 and is also extremely active in the community, where she still teaches at the University of Buffalo School of Pharmacy and Pharmaceutical Sciences. So she is a clinical pharmacist for Hospice Buffalo, and will be sharing her experience with the Macy Catheter.
But thank you for the lovely introduction, especially about my cute little girls. They are quite the handful. They're adorable. So I am the pharmacist at Hospice Buffalo, and just a little bit about Hospice Buffalo. We are part of the Center for Hospice and Palliative Care, and we're a very big and very large old organization here in Erie County, New York, which is Western New York. People may be more familiar with Buffalo, all the snow we get. But I focus mostly on our hospice, and we have a census of about 400 patients per day, and we provide care to everybody, everywhere in their private homes and long-term care. We have a standalone 22-bed hospice inpatient unit where we also take care of patients. And then we do have our palliative care program, which takes care of about 550 patients per day. We see patients everywhere, in their homes, in the hospital, pretty much wherever they need us. And we've been around for a long time. We're kind of a staple here, and New York State is a certificate of need state, so we're the only hospice in Erie County. We're very proud of what we do. I love this place. Our staff is incredible, and really the reason I've stuck around for as long as I have. It's a great place to work, great people, and a great team. We do a lot of good work.
So going back to 2015, and just to share a personal note, when I first started with the Macy Catheter Team in 2014, it was getting used to everything and doing my initial onboarding, and Hospice Buffalo was actually the first agency that I was lucky enough to visit. So it's really neat looking at it now being 2019 that we're still having this conversation and able to look back at 2015 and kind of talk through really the history. But if you could just share a little bit about how did Hospice Buffalo identify the need for the Macy Catheter in 2015?
Right, yeah, so in 2015, we had actually made a pharmacy vendor change over to a pharmacy benefits manager model and using community pharmacies. Originally, we had used one local independent pharmacy to supply all of our pharmacy needs, which really ended up being very much a concierge service and very, very, very expensive. In order to kind of cut those costs to be able to provide our services, we went to the pharmacy benefits manager model. And when we did that, we lose all that 24-hour on-call service that was really heavily used, and the Macy Catheter was really a good option for a safety net for the nurses in the home when symptoms were out of control, and we didn't necessarily have immediate administration or immediate access to medications in the middle of the night or on weekends and holidays like we were used to. When we changed over to the pharmacy benefits manager model, our costs went down significantly, and we were really impressed in home care with what we saw. And we didn't lose quality, but the inpatient unit itself, their costs did not go down with that change. Heavy reliance on things like parenteral medications were really driving the cost there. So basically leadership and finance said, we need to get these costs down, they're way too high. And the catheter became kind of the idea that we had to really tackle those parenteral medications. because it provided an alternate route of medication administration that wasn't oral. And really, with our top expenditure being the parenteral meds, if we could cut those out and still provide the patient what they need, that was what was going to drive those costs down. So really, in 2016, we really saw that those costs hadn't moved. So we basically said, and set a policy that we need to try the catheter first line when the patient can't swallow, instead of just automatically starting to inject the medications. And that's really what kind of drove this paper and the results that we saw.
And then looking back, why was the Macy catheter a good option for Hospice Buffalo at that time? And I know, it was initially introduced when we started that conversation. I believe there was a dinner in HPCO where we met, the former CEO, and then Mary Gordon, who has worked at Hospice Buffalo for quite some time, was familiar with the catheter. But if you could just talk a little bit about kind of what was happening. There was a pharmacy vendor model change, but why did it work initially for Hospice Buffalo?
Well, honestly, it really did. It was mostly that, safety net for home care. When we had to start relying on community pharmacies, oftentimes you can't find things like parenteral meds or some very specific formulation, particularly liquids, that quickly without them having to order it. These pharmacies in general, and I'm sure people are familiar with the community pharmacies, not stocking narcotics quickly or in large quantities because of issues with diversion and robberies. So in order to make sure we had things on hand whenever we needed it, it really made sense to have the catheter around for that immediate administration. And kind of, again, that safety net for our nursing staff, if they forgot to order something or, the patient crashes in the middle of the night, they had something to do with the patient that would, work.
And looking back, could you just talk a little bit, and this is a question that we get all the time, but how was it initially introduced? Because, this is originally for anyone that's new to the catheter that's on the call today, we received our FDA indication in 2014. So if you're thinking back to 2015, we're still pretty new on the market, but at this point when Hospice Buffalo is really starting to adopt, I mean, it speaks to what pioneer and true innovators you all are within the organization. How did you look at even bringing in, this new technology to the organization?
Well, we decided it was worth a try to start using it. And so we wrote our, just internal policies, procedures that you need to have in place, with the QI team. But really when we wanted to start piloting it, we decided to do it in our inpatient unit, more of a controlled environment, smaller number of nursing staff, on-site physicians, basically so we could troubleshoot things very quickly and you don't have a nurse stranded in the home by herself not knowing what to do. And it was, really a great, easy setup that we had with the catheter training. Betsy, if you love Betsy, she came in on site, does this fantastic training with this awesome torso mannequin that you have to see to believe. It's quite entertaining. And, the nurses really do get great, not even just product demonstration, but hands-on experience with the catheter and this basically a mannequin, so they can use it live and practice on it and work out any kinks they have. And we did this over the course of a week, several training times, and got all the staff trained on how to use it. And then we kind of encouraged using it in our inpatient unit. And, obviously there were some nurses in the beginning who were more gung-ho about using it, and some nurses were not. But those ones that were really gung-ho, they really, advocated and, tried to help and show the staff that this really does work, and they were kind of the advocates for getting it going. Once we saw that it worked pretty well in the HIU and we had all those kinks worked out, then we decided to introduce it to home care, which is a much bigger animal on our end. We have a lot of home care staff that needed to get trained. And Betsy came back again with the mannequins, and we did more training, and kind of the same way we did with the inpatient unit staff. And then we felt they were competent to go out on their own in the field. It's pretty simple to use, so we weren't too worried. It's not hard to troubleshoot. Really, it's very simple, and the training was great.
Just to build a little bit on, what factors do you think contributed to it being successful in the HIU, or in the hospice inpatient unit? What did the nurses see, or how did it impact their practice?
I think they saw how quick it was to use. That you can kind of develop medications all at once. It's not individual vials of medication having to be drawn up. They saw rapid symptom control for a lot of their patients, and they saw that it was very comfortable. You weren't sticking the patient with needles. You didn't have ports all over their bodies. It was rather discreet and quite dignified.
do a lot of the HIU nurses, do any of them float to home care? So did that help with any of the education within home care if some had originally had experience in the HIU and then gone to home care?
No, they really don't float around from home care to HIU. If anything, the home care nurses sometimes transfer into the HIU to get a change of pace. But much, you know, it's fairly segregated in their jobs.
And then looking at today, so went through a little bit of a history of, you know, how Hospice Buffalo, you know, found out about the catheter and then initially implemented both in the HIU and home care, but how is it primarily used today?
Most of the time we're using it when the patient can no longer swallow their meds and they've got symptoms that really need to be controlled or, you know, prevented, like in the case of seizures, when they can't get those big giant, you know, Keppra tablets in anymore. We tend to give those rectally. You know, it's a great way to keep somebody home too. If they don't want to go to the hospital anymore, they want to stay home. And then obviously with our inpatient unit only having 22 beds, sometimes it's full and we don't have the option to bring the patient in with their symptoms, you know, and they need a different route. And the Macy Catheter lets us do that at home and keep them there and keep them comfortable.
Yeah. And I apologize if you mentioned it and I missed it, but in one of our previous conversations, you know, just sharing how being able to utilize medications that the patients already have at home when they come into the HIU as well. Would you speak to a little bit of that practice as well?
Certainly, yes. So it was mentioned in the paper that, you know, one of the areas in which we were able to save some costs overall, and it was always a practice that we had done, was when the patient comes into our inpatient unit, they bring their medications from home, and we do utilize those first before ordering more. And obviously, the vast majority of those are oral formulations, tablets, and liquids, which, you know, if the patient comes into the unit and can't swallow, they end up on parenteral meds, and you end up wasting all those oral meds from home. With the catheter, you can use the oral meds, and you give them rectally. You have much less waste on both ends, from ordering parenteral meds to wasting the home meds. So yeah.
Yeah, I thought that when we first were speaking, and since then there's been a couple different agencies I've had the pleasure of having the same conversation with, not having to waste the liquid formulation saves a massive amount of time. So yeah, that's a really interesting area. And of course, you know, just helps be able to spend more time with patients. Real quick, the bottom portion of this slide just talks about some basic information about the Macy catheter. And, you know, going through the registration list, I know the majority that are attending today have some familiarity with the catheter itself, but just wanted to provide a 2-second quick overview for any individuals that might be new to the Macy catheter. This is an image of what the catheter looks like with the balloon inflated. And again, this is a way to provide medication or fluid when the oral route is compromised. So specifically in hospice, it's a great way to provide symptom management, and it provides rectal access to administer those medications and fluids. It is indicated to stay in place for up to 28 days. And if it's expelled, it may be immediately reinserted by a clinician or a trained caregiver. It's made of silicone, so there aren't any latex components. And insertion is a really quick procedure. Typically, after the first time, it's usually 4 minutes or less. And, you know, unlike a Foley insertion, which is sterile, the rectum is not a sterile area, so that also adds to how quickly it can be inserted. And I do have what I promise is a clean and brand new catheter here, but just to give an idea to everyone, and I know I'm pretty tiny on the screen, but you can see against my hand just how small the catheter is. It's 14 French, about 20 inches in length. I don't have the balloon inflated, but it is right here, and when inserted, it sits just against the rectal sphincter. If you're interested in more information on the background of the catheter and patient use examples, we do have a full Macy catheter clinical training that we provide each month, and then can also share individual information with any questions that might come up. One of the areas that we do get asked, and I know we're talking a little bit high level here, but how is medication given through the catheter? And so really quickly, if you are brand new, there's a medication administration port. And essentially, if you have a tablet, you can crush it up, add water, and then you would mix it up into a solution, and then with a syringe that's included in the kit, you would insert into the medication administration port, and then it comes out at the end of the catheter in the distal third of the rectum through these holes here, which again, I know it's really, really small and hard to see. But that's a very, very quick overview of the catheter, but just wanted to share that in case there is anyone new to the device on the call. Okay, so now getting into the cost and quality analysis publication. And as you can see here, this is the image of what the publication looks like. We will be providing a link to the publication following the conversation today for anyone who would like to read the full white paper, or excuse me, the full publication. It is also available. It's open access, thanks to Hospice Buffalo. But starting the conversation, Natalie, would you just share a little bit about why Hospice Buffalo decided to even publish the experience with the rectal catheter?
Yeah, you know, I mean, in medicine, anytime you do something new or working with a new product and you find really interesting results, whether good or bad, you usually want to share that with the community at large to help them out. And we recognized that the catheter was new, and our results were quite impressive with what we saw. And, you know, we're fortunate enough that we, you know, I would say finances are not our top concern all the time. So, you know, some of the smaller hospices that may be struggling, looking for ways to help reduce costs, but keep the care good, you know, these are things we want to share with the community at large. Again, we had really impressive results, which is why we published it. I think even if it was negative results, we may have published it too, but luckily they were good results. But yeah, I mean, just, you know, any kind of innovation in medicine makes you want to publish your data so that others can learn from it.
Great. And then I'll let you take it, you know, anything you'd like to share about how you went through looking at the methodology to the results that you found.
Yeah, so we initially, you know, what prompted the whole thing was we saw the HIU pharmacy costs drop precipitously within the first month of using the catheter after kind of making it our go-to first line guideline. And when we started really just looking at it, we saw the trend after a few months. And we decided to really dig deeper and kind of see where else we were saving things, kind of get a full, you know, economic perspective as to what we were looking at. Most of the focus was on the HIU because just from our accounting data, those numbers were a lot cleaner and easier to follow. But we had a lot of, you know, theoretical potential savings in home care when we started to actually model it.
Great. And then would you mind just talking through some of the results listed here?
Yeah, so you know, for those who haven't read the paper yet, you know, the main gist is that, you know, we projected really a gross net or a net savings of about $92,000 in our inpatient unit. We, you know, took our average monthly spending, calculated out for the year, looked at, you know, the new cost after the implementation of the catheter, calculated out the new projected cost, and subtracted out the catheter cost, and, you know, $90,000 a year is really nothing to sneeze at. That's pretty impressive. And kind of on the bottom point here of the slide, you know, that was just a snapshot in time. We really looked at it for about, you know, 6 months worth of data, and kind of as a follow-up to the paper, you know, just to kind of show this wasn't a 6-month only, you know, time frame. All of last year through 2008, you know, our costs have remained as low as what was found in the paper. And this overall supply costs were only up a couple dollars, so our net savings was still pretty significant across the board. Great. I think the next slide shows it really, really well.
Yep.
They do say a picture's worth 1,000 words, and this graph is usually one you want to show to the finance department when you're trying to justify something. But this really shows nicely what our average costs were prior to implementing the catheter as a first-line, you know, tool for helping with non-oral administration, and it showed our, you know, cost afterwards. And, you know, you can see there's a huge drop in our medication expenditure from the pharmacy side. Yeah. And this slide, you all might be familiar with the hospice compare scores from Center for Medicaid and Medicare Services, which now basically tries to compare all the hospices and show how well everyone's doing. And I just want to take a second to really brag about my staff and brag about our hospice, that we, for the most part, are, you know, I shouldn't even say for the most part, we are incredibly lucky that our staff is as good as they are. Our scores are above average in every category, and they work so hard to do this. You know, and the catheter is just one piece of the puzzle and part of our toolkit to maintain really good care at home. but they, they don't see it in their day-to-day chaos. But when the scores come back in, you can really see that we have a huge impact on the lives of these families and these patients. And it's really quite impressive. So, little chance to brag here.
No, and it's so true. And working with you over the past few years, I mean, Hospice Buffalo truly empowers their clinicians, and there's amazing patient care. So it's really neat to be able to share, these results as well. And again, as you mentioned, for anyone who might be newer to hospice, this is something that you can go on Hospice Compare. CMS puts it out, and you can look at any agency that is certified and look at the different results. It's really interesting, and it's a great tool. Okay, so the next portion of our presentation, this is really looking at a lot of the questions that were submitted. So again, many individuals are new to the catheter, and again, though giving medications rectally has been done for hundreds of years, giving it through the Macy catheter is a new way of administering medications. So with that, there are always questions around adoption. So when Natalie and I were first talking, we thought maybe it would be something beneficial for the community just to be able to share what Hospice Buffalo's experience has been for anyone, again, that maybe you've been utilizing the catheter, you're looking for some new ideas, you're looking for a refresher, or you're just considering if this might be something that would be beneficial for patients at your agency. So with the first question, Natalie, would you describe the culture at Hospice Buffalo with regard to acceptance of the different routes of medication administration?
Yeah, so, I would say we have a very heavy emphasis on bowel management here at Hospice Buffalo, and we affectionately call ourselves the poop police. So our nurses, for the most part, are very comfortable with rectal interventions, particularly surrounding the idea of constipation. It wasn't that far of a stretch either. A lot of our medications, when patients couldn't swallow, prior to our pharmacy benefits manager model, we were having suppositories compounded. So, anything rectal really wasn't too difficult for our staff to really, be okay with. They were used to the rectal interventions. It was just a new device they had to learn how to use in order to do it. It wasn't anything foreign to them. They were already comfortable with rectal medications.
Yeah, and I'd say too, looking back, it was definitely something that leadership was supportive of as well. So from all directions.
Yeah.
Yeah. And that, with all the different agencies that we work with, that really plays a huge part, because when the clinicians come in and have questions, to be able to have that support and know, okay, we're figuring this out together, really adds to the different factors that lead to success. So challenges, as a pharmacist specifically, what are some of the challenges that you have faced as the organization has adopted the Macy catheter into practice?
Yeah, so there's a couple. I would say, from the overall adoption, the inpatient unit had a very heavy history of parenteral med use. There's still a heavy reliance on parenteral med use and a comfort level with parenteral med use. So getting them to switch to rectal still is a little bit of a challenge. They still prefer their injectable medications, but we do use the catheter quite often. I think there's a little bit of hoping that the injectable seems to work better, even though, that's never really always playing out. In home care, it's more just learning to use the new device for our clinicians, and more of the challenge is the family and the patient, when they hear the word catheter. But the nurses in the field, once they use it a few times clinically, they have no problem continuing it on. And then, when it comes to medications themselves, as the pharmacist, I'm a little fanatical about dose conversions and making sure the medications are safe and being dosed appropriately. And just like with parenteral medications, sometimes there is a dose conversion that needs to happen when you change routes from oral to something else. And the same thing happens when you have to go rectally. And unfortunately, there's a lot less data in the literature about which medications can go rectally and what their absorption is. Best we can do sometimes is an educated guess, but most of the symptom management meds that we use do have literature and data to help support that. It's just remembering, because most people remember the parenteral conversions, but they don't remember the rectal conversions. They do it a lot. So I'm constantly harping on them to make sure that they're checking on the conversions and making sure that we're giving the medication safely.
And that's something that, we get questions about across the board. And I think, even you think about adopting a new technology, but then this is, an intervention that facilitates medication administration. So how do you, how you go about supporting your team and developing different tools to make sure that they have the information that they need. And we'll talk about some of those tools definitely in a moment. But what would you describe as some of the main successes of incorporating the Macy Catheter care into symptom management?
I think really it's the ability to keep the patient home and keep the symptom managed. When there's a crisis, you can't, the patients don't want to go to the hospital, and most of the time hospice is, part of our goals is to keep patients out of the hospitals and keep them from going through all that, really intensive, medical management that maybe it's not appropriate at end of life. So, I mean, this keeps people home, keeps them comfortable, and that's, it allows the nurses to do it quickly from the moment they walk in the door. They don't have to order new meds. They don't have to get new formulations. They just go in, take the meds they've got, and do it. And it happens very quickly, and the patient gets managed very, very fast.
And would you say a lot of that is because they're able to use many of the medications that they've been taking orally in the catheter?
Absolutely. And, one of the things that we used to, prior to our pharmacy vendor change, one of our big practices was always to change from tablets to liquids for everything as soon as the patient was having any trouble swallowing, which was not only a cost issue, but it was a time issue. You have to wait till the meds show up and be delivered. This is, you take the tablets you have and you just crush them up and give them. So you don't have to wait for pharmacy deliveries. You don't have to wait for new scripts to get signed. You just take what you have, and you may or may not have to adjust the dose, and you manage the patient right then and there.
Okay, a little bit more on education. We get a ton of questions about nursing education. Could you just talk a little bit about, following the initial training where, Betsy, who, for anyone who has not met Betsy, she's our incredible hospice educator, and she comes in to, Betsy is on the call today, and I think she sent a little hello earlier, but she comes in with a torso and will do all of the education, and it's a great training, great hands-on, especially for those that are new to the Macy catheter. We since have some additional options with a lot of recorded trainings, et cetera, with all the same information. But specifically speaking, once you have that initial training, how do you, continue to educate new nurses that join the organization?
Yes, we don't have our own butt mannequin. Fortunate. Maybe I'll ask our CEO for that for Christmas next year. But really, it's quite simple. The nurses learn about it in orientation. They're shown how to use it, and then they have to do it in field, whether out with their preceptors as part of their orientation. Part of the checklist, they do it live, show competency, and continue on. And fortunately, it's really not a difficult tool to use, so it doesn't take a lot of intensive training to make sure that they know how to do it. In the event they forget when they're in the moment, it comes with instructions that are pretty simple to follow.
Great. And then any tools that you've created for the staff?
Mostly it was for the physician. So the catheter kit I know does come with kind of a little mini, I'm going to say, drug formulary of commonly used medications and kind of their dose conversions. I took that and expanded it out to other meds that we commonly see going through the catheter, and gave that to my physicians to, be able to help with dose conversions if the staff don't call me directly. So there, I expanded the list that was there, and that seems to be pretty helpful because the nurses have access to it also. Usually in their bags, they either have a printed copy or an electronic copy on their tablets that they use in the homes. They can access the medication list that I created as well.
Yep, no, that's great. And what Natalie is referring to, we have we call it a medication reference, and essentially it's all the common literature and research that talks about oral versus rectal bioavailability. So you have an option to be able to look at those particular publications. In addition, Optum actually put out a medication reference as well, and that's on our website. And it's a great just initial tool for some of the common medications that are given through the catheter. Last education question, how do you educate and introduce Macy catheter to families? Because that is definitely something we are asked all the time. Again, it's as a nurse in nursing school, figured out how to, insert an IV, and you figure out that talk track, but, how do you guide individuals who are new to the catheter and how to start that conversation with families?
Yeah, so what I always find interesting is that the patients are more willing for the nurses to, do rectal interventions for their bowels, enemas, disimpactions, things like that, then they are willing to talk about the Macy catheter. They hear the idea of it, but really it just becomes practice on the part of the nursing staff to explain what it is and how to use it. And when I think families learn that it's going to keep the patient comfortable, or you're really going to manage a symptom that might be potentially scary for them to witness, like a seizure, they're a little less hesitant to let you try it. And I think part of it's because the catheter stays in, whereas, a rectal intervention for bowels is kind of okay, we'll suffer through it for a half an hour and then it's done. It's a little more medicalized than that. So, it just comes with time. Once our nurses became comfortable with using it, they were more comfortable in explaining it. And, some of our nurses, just their skills in speaking to the families are amazing as it is. And they're just really able to convince them that this is what's needed to keep the patient home, keep the patient comfortable, keep the symptom managed. And usually when the patient can't swallow, the family is in crisis and sees that, and they are willing to, listen to what you have to offer. And most of the time, though, they're expecting parenteral meds. So when you say rectal first, they kind of look at you funny. But when you explain that we try not to do, the parenteral medications in the home, this is easier for them to manage, it's actually potentially a little safer for them to manage. Things are not necessarily sterile and there's no needles involved. It goes over a little better.
And that's a great point. I'd say the majority of organizations that we work with, the introduction to families happens in kind of two different scenarios. The first would be crisis, like you said, where everything else has been tried and, the family just wants to try and find something that's going to bring, quick symptom management to their loved one. And the second, we're starting to see it more as the catheters, becoming more of a standard of care across the hospice community, and that is introducing it before it's even needed. So again, this is something that is a new way of giving medication, but even during the admission process, we have a lot of agencies that will just talk to it and introduce what it is and just say, here is it's a catheter that's going to enable you to stay in the setting of your choice, and you're going to be able to take medications that for the most part we're taking orally as well. That's a great point. Okay, so last couple of questions, and we'll get into live Q&A, is just, in general, overall impact on practice. So to date, and, working with this really since when we first started in 2015, what would you consider to be the biggest impact or value of utilizing the catheter at Hospice Buffalo?
I mean, really, it's the ability to care for the patient, keep them home, keep them comfortable, manage the symptom where they're at, as opposed to transferring them to a higher level of care, which is oftentimes very stressful. The symptoms get managed very quickly. From a quality perspective, it's very easy for our staff to use. We tried to, in the paper at least, look at potential things like nursing efficiency gains on MedPass, because they can literally throw all those tablets in the pill grinder at the same time and administer 6 meds at once. Rectally, as opposed to, every single dose of like an injectable having to be drawn up separately and done with sterile technique. It's a little harder to quantify on a day-to-day, but the nurses all say it's really fast. They can get things done a little quicker. And then obviously, administration always wants to know about the outcomes, besides patient impact, they want to know the cost. And, we've at least seen a huge cost impact, which made administration very happy.
And any advice, so this could be anything that you'd like to share with agencies who are thinking about incorporating the Macy catheter, and maybe it's around what to consider with education. I mean, looking back, is there something that you wish you would have known that took a little bit to figure out at Hospice Buffalo?
One of the things that I think would be most helpful is to kind of almost do a preemptive cost analysis. Try and figure out, look at the catheter cost for your organization, look at where it might fit in, and does it fit in with your culture and care, and where are the areas it's going to help. We kind of did it more retrospectively after, and we were hoping that we'd have good outcomes with cost when we used it. But, you can kind of almost do that without necessarily purchasing them any right away and take a look at it and then be able to justify that changeover. And then, from the clinician side, you have to make sure that your organization is bowel friendly as we are. If your staff aren't comfortable with rectal meds and your model of care is not comfortable with rectal administration, it'll never be part of your day-to-day. Really, you have to look at where it's going to fit into your specific culture and organization and finances, where it's going to help.
Yeah. Well, and again, you know, Hospice Buffalo has been a true innovator, especially being one of the first hospice agencies to really adopt the catheter in their practice. So thank you so much for sharing your experience and going through all this. You know, I know we've been talking about the catheter together for a long time now, but it's really helpful to be able to share. And it's amazing to look back just from where we started to where we're at today as well.
I can't even believe it's been almost 5 years.
I know. Well, with that, we received a couple questions here, and I can go ahead and get started on those. But that concludes the main portion of our presentation. So feel free, if you have additional questions, you can go ahead and click the Q&A and submit those, and we'll get to as many as we can. I know we ran a little bit over, so we'll probably just spend about 5 minutes or so and be respectful of time. I can go ahead and start with one of the first questions that was sent, and let's see, that was, what are some of the common medications that you give through the Macy catheter at Hospice Buffalo?
All your big ones for symptom management. So the pain medications, opioids, things, antipsychotics, anti-anxiety medications like Ativan, benzodiazepines. We give all those, you know, traditional, usual symptom meds. And then honestly, I see a lot of maintenance meds like antidepressants going through to try and maintain patients. Because sometimes stopping a medication when they can't swallow it means they go through withdrawal from that medication. So antidepressants, steroids, things like that tend to get continued, but definitely all the big major symptom management meds like the opioids go through.
And then how do, and this is actually around the order for the Macy catheter, which is interesting, but how do clinicians place an order for the Macy catheter? So is it a standing order, or how do they go about recognizing, or excuse me, getting a catheter for their patients?
We don't have it necessarily as a standing order yet. So in home care, when the clinician sees the need for the catheter, we have a pretty quick call system to our physicians to okay the catheter, and the nurses enter their orders and, you know, insert it. In the inpatient unit, kind of the same idea. Either the physician sees the need right away and writes the order for the Macy catheter to be inserted, or the nurse calls up and says, hey, they're no longer swallowing, can I put it in? And then they get the order verbally that way. It's more done on a need basis as opposed to a standing, can do it whenever they want order.
Okay, great. And this is related to medication absorption. So how quickly are medications absorbed, once they are administered through the Macy catheter?
Varies by medication, but rather quickly. So it's going to be somewhere between, you know, IV sub-Q and orally, which, you know, orally can take up to an hour, depending on the medication. And I know there was a paper published that looked at phenobarbital suppositories rectally versus the phenobarbital, you know, put into this microenema suspension with the catheter, and it was incredibly fast, like 15 minutes versus, you know, 45 or something like that. So it can be quite rapid.
Great. And to your point, it really does vary on the medication itself. Yeah, but great question. Okay, so the next question is, what alternative treatment methods, and I believe this is related to medication routes, does the Macy catheter frequently replace?
Obviously, it replaces the oral. Sublingual routes, not always effective if your patient can't swallow or you're giving large volumes of meds. And then obviously the parenteral route, anything subcutaneous, anything IV. And it also replaces suppositories because the medication doesn't have to be compounded then, and you don't have to stick those little individual bullets into the rectum. So it replaces all of that.
Great. All right. Well, I think that is the majority of questions. I don't see any more coming in here. We can hang on for another minute, but Natalie, is there, you know, anything else that we've forgotten or that you'd like to share?
You know, just from the standpoint of using it clinically, we've seen a lot of really interesting things. We've started doing more hydration with it. You know, it's really interesting for those patients who want, you know, IV bags, you know, hooked up to them because they're dehydrated. We can use the catheter, and we've been doing that a little more frequently than we had in the past, which seems to help. But yeah, it seems to be this catch-all to be able to give medications and fluids for patients, which has its ups and downs. You know, sometimes the patients' families get a little too excited that they can get everything through the catheter and they think they're going to keep the patient alive longer. But, you know, it's also good because not everybody who gets a catheter is actually acutely dying. so you can still give those maintenance medications for somebody who's just nauseous and vomiting for a few days, and not have them like compensate by not being able to take their maintenance meds. So it kind of runs the gamut of, you know, being able to care for the patient at all spectrums.
Yeah, great. Well, thank you so much for your time, and thank you so much for sharing your background and everything that you and the Hospice of Buffalo family does. I would really, really appreciate sharing your experience.
Well, thanks for having me on.
Absolutely. And to all of those that are on the webinar, again, you'll receive an email with links to more information. So for the publication, which Natalie discussed today, as well as links to, if you'd like to view a recorded version of this, we'll have that posted to the website early next week. So thank you all again for your time. If I missed any questions, we'll make sure to go through and send individual responses following the webinar today. Thank you so much, Natalie. Really appreciate your time.
Morgan.
All right, take care.
You too.